Good morning, students. Today's topic is exocrine pancreas and pancreatic function test. So the pancreas, liver and gallbladder are the accessory organs of the digestive system. So before going into the details of the small intestinal secretions or the physiological activities of small intestine, it is important to study about the physiological role of these accessory organs because their secretions will affect the activities of the small intestine. So the learning objectives of today's topic are: we will see the functional anatomy of the pancreas, exocrine functions of the pancreas and pancreatic function test. The pancreas is a dual organ having two functions, endocrine and exocrine functions. So as you already know, pancreas involves in the production of hormones, which is called endocrine function, and it involves in the secretion of digestive juice, which is called the exocrine function. Coming to the functional anatomy of the pancreas, exocrine part. So it is an elongated accessory digestive gland which lies retroperitoneally and transversely across the posterior abdominal wall. Anatomically, it is divided into head, neck, body and tail. And physiologically, it is divided into exocrine and endocrine. So if you see the structural characteristics in this picture, so we have acinar cells. This is pancreatic acinus and the pancreatic cells. So pancreatic islets of Langerhans, which is responsible for the secretion of hormones, and the pancreatic duct, and then from the duct the pancreatic juice is secreted. So this is the structural characteristics of the pancreas. Now the exocrine functions of the pancreas. So the digestive juice secreted by the pancreas is called pancreatic juice. So the volume is 500 to 800 ml per day and it is highly alkaline, that is pH 8 to 8.3 due to high concentration of bicarbonate, and the specific gravity is 1.0110 to 1.018, and composition it contains 99.5% water and 0.5% of solids. So the organic constituents of the pancreatic juice are enzymes and other substances like amylase, lipase, protease and trypsin inhibitor, and the traces of albumin and globulin are present. And the inorganic substances are electrolytes like sodium, potassium, calcium, magnesium, zinc and bicarbonate, chloride, etc. So this electrolyte composition varies with the rate of secretion. That is, as I have told you previously in the secretion of saliva, at high flow rates secretion is not modified, but at low flow rates, because the saliva has to pass from this primary secretion state to the from the acinus to the through the ducts and the finally oral cavity. So this, like same wise, pancreas also at low flow rates its composition is modified. So coming to the functions of the pancreatic juice, it has a digestive function, main role in the digestion of proteins and lipids, and mild digestive action on carbohydrates. Digestion of proteins is carried out by proteolytic enzyme trypsin and chymotrypsin. Trypsin helps in the digestion of milk and in blood clotting. So for the digestion of lipids, the enzyme required is pancreatic lipase, which is a powerful lipolytic enzyme. Its activity is accelerated in the presence of bile. About 80% of fat is digested by the pancreatic lipase. Digestion of fat by pancreatic lipase requires two main factors: bile salts, which are responsible for emulsification of fats prior to their digestion, and co-lipase, which is a coenzyme necessary to hydrolyze dietary lipids. So the deficiency or absence of pancreatic lipase leads to excretion of undigested fat into the feces. The digestion of carbohydrates and proteins occurs by the enzymes pancreatic amylase and pancreatic proteases. So the amylase converts starch into dextrin and maltose. It is an active form. It is the only amylatic enzyme present in the pancreatic juice. It hydrolyzes glycogen, starch and other complex carbohydrates except cellulose to form the disaccharides, that is dextrin and maltose. And the proteases, these are also called proteolytic enzymes, which include 3 endopeptidases, that is trypsin, chymotrypsin and elastase, and 2 exopeptidases, carboxypeptidase A and B. Endopeptidases break the peptides in the middle, whereas exopeptidases break the chain near its end, releasing single amino acid. So the trypsin is the most powerful proteolytic enzyme in the pancreatic juice, and it is secreted in inactive form, which is activated by the enterokinase. So this activates the also activates the trypsinogen and autocatalytic reaction. That is, trypsinogen is converted to trypsin by enterokinase, and trypsinogen is again converted to trypsin by the form trypsin. So it is an autocatalytic reaction. So it hydrolyzes proteins into proteoses to polypeptides. It activates the trypsinogen and other pancreatic enzyme. So likewise, in the proteases, we have trypsin, chymotrypsin and elastase, and along with it carboxypeptidase A and B. So the neutralizing action or function of the pancreas is that when acid chyme enters intestine from stomach, pancreatic juice with large quantity of bicarbonate is released into the intestine. Presence of large quantity of bicarbonate ions makes the pancreatic juice highly alkaline. The alkaline pancreatic juice neutralizes acidity of chyme in the intestine. So it is an important function of pancreatic juice because it protects the intestine from destructive action of the acidic chyme. So coming to the secretion of the pancreatic juice. Pancreatic enzymes are derived from the amino acids and synthesized in ribosomes attached to the endoplasmic reticulum of acinar cells in the pancreas. After synthesis, enzymes are packed by the Golgi apparatus and stored in the cytoplasm. On stimulation, they are released from the acinar cells into the pancreatic duct. So finally, the secretion is poured into the duodenum through the main and accessory pancreatic ducts. And within the cells, these enzymes are stored in inactive form, that is proenzymes. They become active only after mixing with the duodenal contents. So the brush border enzyme enteropeptidase is required for the activation of the initiating the activation of the enzymes. So secretion of bicarbonates from the cells of pancreatic ductules and released into the pancreatic duct. So the mechanism is, so in the picture I will show you. So this is the picture, mechanism of secretion of bicarbonate. So in the blood, because of acidification by the sodium hydrogen exchanger, sodium hydrogen and potassium proton ion and ATPase pumps in the basolateral membrane, resulting in the formation of CO2. CO2 diffuses into the ductal cells where it combines with water to produce H2CO3, which again dissociates to produce H plus and HCO3 minus. This H plus diffuses out into the blood again because of the sodium hydrogen exchanger, and HCO3 flows down its electrochemical gradient along the luminal membrane via the chloride bicarbonate exchanger. So this chloride is recycled back into the lumen, and the sodium enters the luminal fluid by flowing through the tight junctions. So this is the source of the bicarbonate from the blood CO2 into the lumen of the duct. So efflux of the potassium through the basolateral membrane maintains the intracellular electronegativity. So this is the mechanism of secretion of bicarbonate by the ductal epithelial cells. So if you remember, the same like the salivary secretion, pancreatic juice secretion is also primarily from the acinar cells and then secondarily in the ductal. So what happens in the SNR cells? So the SNR fluid is isotonic and resembles plasma in its concentration of sodium, potassium, chloride and bicarbonate. So it is stimulated by cholecystokinin and acetylcholine. So in the intralobular and extralobular ductal cells, what happens? There is higher concentration of potassium and bicarbonate because of this mechanism. And coming to the regulation of pancreatic secretion, both the neural and hormonal mechanisms are involved in the regulation of this secretion. So the later hormonal mechanism play a predominant role. So in salivary secretion regulation, we have seen that neural regulation is very predominant. So here in pancreatic secretion, hormonal mechanism is predominant. So neural regulation is through vagal efferent supplying the exocrine gland of pancreas, and hormonal regulation is through secretin, cholecystokinin, gastrin and somatostatin. So we can consider the pancreatic secretion under three phases: cephalic, gastric and intestinal phases. So what happens in these three phases we will see. In the cephalic phase, secretion of pancreatic juice by stimuli arising from the head region is called cephalic phase. So this is purely under nervous control. Conditioned and unconditioned reflex. So this is characterized by very little flow of secretions from the ducts into the duodenum because of secretion of small quantity of enzymes and aqueous component. The conditioned reflex, that is, it is initiated by sight, smell and thought of the food or hearing of the food. And unconditioned reflex is initiated by stimulation of taste buds by the food in the mouth cavity and also by the act of chewing and swallowing. The efferent impulses from the cerebral cortex and from the mouth reaches the dorsal nucleus of vagus, and stimulation of efferents in the vagus nerve supplying the exocrine part of pancreas enhance the secretion from both SNR as well as ductal cells. Okay, so finally, because of the conditioned reflex, that is sight, smell and thought and hearing of food, and unconditional reflex from the mouth, that is taste of food, causes the stimulation of the vagus, dorsal nucleus of vagus and then vagus nerve, which supply the exocrine part of the pancreas, which causes increased secretion from both SNR and ductal cells. So that is the cephalic phase. So you have to draw this picture and then explain. In the gastric phase, secretion of the pancreatic juice when food enters the stomach is known as gastric phase. So this is under hormonal control, and along with it little neural control is also there. So the presence of food in the stomach by, that is bolus, causes gastric secretion. So these are the stimulants for the secretion of pancreatic juice. And the hormone responsible is gastrin, which is secreted from the antral G cells. It is released into the blood. While reaching the pancreas, it stimulates the SNR cells and produces a low volume, high enzyme pancreatic secretion. And neural control is by vagal stimulation, which occurs by the distension of body of stomach, resulting in secretion of low volume pancreatic juice. And in the cephalic phase, enzymes are secreted very little amount, but the aqueous component is more in the cephalic phase. So that is the difference between cephalic and gastric phase. So finally, gastric phase is under mainly hormonal control. The next is intestinal phase. Secretion of pancreatic juice when chyme enters the intestine is called intestinal phase. This is also under hormonal control. So what are the hormones which mainly acts here? These hormones are secretin and cholecystokinin. So presence of chyme in the intestine is a stimulator, and the hormones acting are secretin and cholecystokinin. So in detail we will explain about these hormones in the coming classes, but a brief description of secretin is that it is the first hormone discovered by Baylis and Starling. It is secreted from the endocrinal S cells located in the epithelial cells of the mucous membrane of duodenum and jejunum. And the stimulant for the release of secretin is low pH of chyme, presence of the gastric HCl. And the action is that it neutralizes the HCl present in chyme and protects the intestinal mucosa, and it provides a required pH for the activation of pancreatic enzymes. So the low pH of the chyme causes secretion of secretin, which causes secretion of alkaline pancreatic juice in the duodenum, and then it neutralizes the HCl and increases the pH of the chyme. So that neutralization of the by the HCl and increasing pH will cause again negative inhibition of the production of secretin. So that is a negative feedback regulation of the secretin hormone. And coming to the cholecystokinin, it is previously it is thought of two separate hormone, that is cholecystokinin and pancreozymin, but however it has proved that both actions are brought about by the single hormone called CCK-PZ, that is cholecystokinin pancreozymin, or simply CCK. So it is secreted from the endocrinal eye cells in the epithelial cells of the mucosa of duodenum and jejunum. So a stimulant for release of CCK is amino acid, fatty acid, and monoglycerides present in the chyme. So it acts via blood to the pancreas and causes secretion of the pancreatic juice rich in enzymes by causing discharge of zymogen granules from the pancreatic acinar cells. So it also causes contraction of the gallbladder to release bile and potentiate the effect of secretin to produce more alkaline pancreatic juice. So that is the main action. It in turn stimulates the secretin to produce more alkaline pancreatic juice. So it is also regulated through positive feedback mechanism. So the increased bile and pancreatic juice secretion in turn stimulates the production of more cholecystokinin. So this potentiation effect of the cystokinin and secretin has a more effect on the secretion of the pancreatic juice. CCK potentiates the effect of secretin. By itself, CCK has no effect on bicarbonate secretion. So they are potentiators of each other's action. Small concentration of CCK and secretin together can produce significant amount of pancreatic bicarbonate and enzymatic secretion. So that is the main important point you need to know here. So intestinal phase is controlled by secretin and cholecystokinin. Secretin is regulated by the negative feedback mechanism and cholecystokinin by positive feedback. So even though they are present in smaller amounts, they cause potential secretion of the pancreatic juice. So it finally produces the alkaline pancreatic juice secretion, which is rich in bicarbonate and also rich in enzymes. So till now we have seen the regulation, functions, and the mechanism of secretion of the pancreatic juice. So now we will see a few disorders of the pancreas. So the common disorders are acute pancreatitis, chronic pancreatitis, cystic fibrosis, and pancreatic tumor. So acute pancreatitis is an acute inflammatory disease of the pancreas which results from autodigestion of pancreatic tissue by the proteolytic enzymes which leak out of acini and are activated within the pancreas. Patient usually presents with acute pain in the upper abdomen, nausea, and vomiting. So it is a serious disease and may be fatal sometimes. So marked elevation of the serum amylase threefold is usually the diagnostic of this acute pancreatitis. And the chronic pancreatitis is again chronic inflammation of the pancreas which results in slow destruction of tissue resulting in deficiency of pancreatic secretions. The patient may develop diabetes mellitus due to pancreatic endocrine deficiency and the digestive disturbances due to deficiency of the pancreatic enzymes. So it results in steatorrhea characterized by bulky, foul-smelling, pale and greasy stools. So this condition resembles the intestinal malabsorption, and from which it can be differentiated by secretin cholecystokinin tests. So all these are tests called pancreatic function tests, which we will discuss in the following slides. Cystic fibrosis is a disorder of pancreatic secretion. It results from defect in chloride channels caused by mutation in the cystic fibrosis transmembrane conductance regulator gene, CFTR gene. So it is associated with deficiency of pancreatic enzymes resulting in steatorrhea. And pancreatic tumor, that is a cancerous condition. So where there is deficiency of the pancreatic enzyme characterized by same features of the chronic pancreatitis. So the surgical procedure for this tumor is that we have to remove the pancreas, that is pancreatectomy. So the last part of today's class is the assessment of pancreatic function, otherwise called pancreatic function test. So these are performed to evaluate the normal functioning of the pancreas to detect abnormality or present if any. So these tests evaluate the functioning of exocrine pancreas, part of the pancreas, by analyzing the juice and analyzing the products of digestion and also estimation of serum amylase levels. So first of all, we will see the measurement of enzymes in that amylase or alpha-1,4-glucosidase, which is the major enzyme which digests the starch of carbohydrates. So it contains the P and S pancreatic and salivary isoenzymes. These two can be distinguished by inhibition test. The normal amylase level in serum is 50 to 120 units. The level rises within 5 hours of onset of acute pancreatitis. So this is the most important condition for the estimation of the serum pancreatic amylase levels. Acute pancreatitis. The level reaches a peak, that is 4 to 6 fold within 12 hours. And within 2 to 4 days of the attack, the level returns to normal. As the serum amylase level starts falling, urinary amylase level rises. Amylase level in the blood is mildly increased in cases of cholecystitis, peptic ulcer, diseases of mesentery, and obstruction of intestine. And in chronic pancreatitis, there is no change or only mild elevation is noticed. So, if the sample is collected too early, the serum amylase level may not show the expected rise. And if the sample is collected too late, the amylase may be low due to the necrosis of pancreatic tissue. So the calculation of clearance ratio will avoid all these defects. So in patients with acute pancreatitis, the ratio varies from 7 to 15% and normal ratio is 1 to 4.5%. And don't worry about the formula, it is again same as for the renal clearance. So for estimating the pancreatic lipase enzyme, the test is fecal fat excretion test. The subject is placed on a diet containing 100 grams of fat per day. The stools are collected over 3 to 5 days and tested for fat content, and the results are interpreted as normal fats are digested by lipase and about 5 to 6 grams per day are excreted in stools. In patients with exocrine pancreatic insufficiency, it may increase up to 40 to 50 grams per day. That is, fats are excreted in case of pancreatic insufficiency to the 40 to 50 gram per day from the normal value of 5 to 6 gram per day. So from that we can understand the deficiency of the pancreatic lipase enzyme. And also we can conduct fecal nitrogen excretion test and tripeptide hydrolysis test and the dual label Schilling test for all the different substances present in the products of digestion, that is fat products, protein products and carbohydrate products. And the hormones involved in the pancreatic secretion. Analysis of pancreatic juice collected after the direct stimulation of pancreas by the secretin test and combined secretin and CCK test. So the secretin test is used to detect diffuse pancreatic disease and which is based on the physiological principle that pancreatic secretory response is directly related to the functional mass of the pancreatic tissue. In standard assays, secretin is given intravenously in a dose of 0.2 gram per kg of synthetic human secretin as a bolus, and the normal values for standard secretin tests are volume output is more than 2 ml per kg per hour and bicarbonate concentration is more than 80 millimoles per liter and bicarbonate output is more than 10 millimoles per liter in 1 hour. So these are the normal values of the standard secretin test. The most reproducible measurement giving the highest level of discrimination between normal subjects and patients with chronic pancreatic exocrine insufficiency is, it appears to be the maximal bicarbonate concentration. That is the most reproducible measurement. There may be dissociation between the results of secretin tests and other tests of absorptive function. For example, patients with chronic pancreatitis often have abnormally low outputs of bicarbonate after secretin but have normal fecal fat excretion. Thus, secretin test measures the secretory capacity of the ductular epithelium, while fecal fat excretion indirectly reflects the intraluminal lipolytic activity. It must be noted that abnormal secretin test results suggest only that chronic pancreatic damage is present. So this point you have to remember. Abnormal secretin test results suggest only that chronic pancreatic damage is present in that person. The amount of human elastase, the normal value is 175 to 1500 microgram per gram of the stool, reflects the pancreatic output of this proteolytic enzyme. The decreased elastase activity in the stool, that is less than 100 microgram per gram of the stool, is an excellent test to detect severe pancreatic exocrine insufficiency in patients with chronic pancreatitis and cystic fibrosis, provided that the stool specimen is solid. The fecal elastase 1 and small bowel biopsy are useful in the evaluation of patients with suspected pancreatic steatorrhea. The fecal elastase level will be abnormal and small bowel histology will be normal in such patients. And the estimation of fat in the stool is done by fat balance studies. When feces contains split fatty acid, it points to a normal pancreatic function, but defective absorption. If fat is excreted, if it is neutral fat, it is due to defective digestion and is more in favor of pancreatic disease. Steatorrhea does not occur until intraluminal levels of lipase are markedly reduced, underscoring the fact that only small amounts of enzymes are necessary for intraluminal digestive activities. So the normal fat level in stool is, in children up to 6 years, it is less than 2 gram per day, and thereafter it is 2 to 6 gram per day, and in steatorrhea it is more than 7 gram per day, and as I have already told you, it's severe pancreatic insufficiency, it may increase up to 40 to 50 gram per day. And one more test for the analysis of pancreatic juice collected after indirect stimulation of pancreas is Lund test. In this test, pancreas is stimulated indirectly by ingestion of a test meal containing fats, proteins and carbohydrates, and assessment of trypsin activity is made from the pancreatic juice collected. The mean trypsin activity of less than 6 international units per liter indicates the presence of pancreatic exocrine insufficiency. So that is Lund test. You have to remember that. And finally, to summarize, we have seen the exocrine part of the pancreas secretes the digestive enzymes from the acinine, and the endocrine part secretes the hormones from islets of Langerhans, and the major part of body's metabolism is controlled by the pancreas. So we have seen the mechanism of secretion of the pancreatic juice in the picture. From the blood, the CO2 enters into the ductal cells. You just remind of that picture, and the CO2 combines with H2O to produce H2CO3. From there again H plus and HCO3. That HCO3 enters into the lumen and dissociates, flows in the lumen. So that luminal pancreatic duct secretion contains high concentration of bicarbonate, and potassium is also entered into the ductal cells to maintain the electrical negativity inside the cell. And after that, we have seen the functions, the digestive functions. It digests the proteins, fats and carbohydrates, and also we have seen the neutralizing function. It neutralizes the acidic secretion from the stomach to the juice entering into the intestine. It will be converted or neutralized by the pancreas, and also it may be increasing more than the neutralization, that is, it actually converts to alkaline juice when it enters into the small intestine. And after that, we have seen the regulation of the pancreatic juice, that is cephalic, gastric and intestinal phases. So the cephalic is mainly under neural control, and the gastric and intestinal are under the hormonal control. In the gastric phase, the hormone is gastrin, and in the intestinal phase, the hormones are secretin and cholecystokinin. So these secretin and cholecystokinin potentiate each other, and so they cause increased amount of enzymes and increased amount of bicarbonate in the pancreatic juice, which is responsible for the change of the acidic juice into the alkaline juice in the small intestine. And lastly, we have seen the various pancreatic function tests. So analysis of pancreatic juice and the products of digestion, that is fat, proteins and the carbohydrates, digestive products, and also the estimation of serum amylase, that is which is mainly raised to 3-fold in the acute pancreatitis. Okay, so hope you all understood this pancreas, which is the accessory organ of the digestive system. So that's all. Thank you all.